Yeah. Okay, pretty loud. Okay, hello. I think it's time to get started. And I think I have 20 minutes, and I'm going to try to stay on that because I've given several hour-long versions of this talk, so I'm going to try not to get in the weeds. But it's so nice. I have some of my residents here and some co-faculty, but it's nice to see a lot of people here that I do not recognize. So I want to go through some content here, and then I want to have a little bit of time at the end for some discussions. If you guys have extra questions, things that you wanted to get answered that you feel like I didn't cover in this talk, or if you want to kind of discuss some of the points that I bring up here. Oh, hello. Oh, you want to be in the front row? Okay. So I'm Julie Rice. I'm the Director of SIM Education in the Emergency Department at Johns Hopkins Hospital. I have a master's in medical and healthcare simulation that I got at Drexel University, and I work closely with Sharon Griswold, who used to run that program. She helped develop this talk, and we usually give this together. Unfortunately, she couldn't be here, but I credit her for some of the original content here. And it's too bad she can't be here because she's quite amazing. So if you ever have a chance to see her speak, take advantage. I'm also associate faculty at the Armstrong Institute for Patient Safety, and I work on projects with that institute. And again, like I said, I've got a master's in the sim education, which is kind of like a med ed master's, except I did a little bit more work in simulation, debriefing, things like that. I have nothing to disclose. If anybody wants to give me a reason to disclose things in the future, I would love to. A couple objectives here. We're going to talk about cognitive load theory, some signal to noise stuff, but really what I want to have people go home with is some concrete strategies. I want you to have these concrete strategies so that you can appropriately challenge your advanced learners in the simulation lab. So when I say advanced learners, what do I mean by that? I think a lot of people think I'm talking about senior residents, and they're included in the group. Also, you're maybe very experienced APPs, but I'm also talking about faculty. And I think a lot of programs are starting to see simulation as an opportunity for faculty learning. So I want to include that group in this as well. Now, 100 years ago, that was me as an intern. I was totally clueless. And as educators, our job is to get that clueless person into like a superhuman, pretty much. Towards the beginning, it's pretty predictable what people are going to need to learn. Basic ACLS stuff, basic intubation stuff, some really basic skills. But as you get closer to that Superman, it gets a little less predictable what people are going to want to be learning in the simulation lab. And it's really important for you to nail their needs in the simulation lab because simulation is very resource intensive. The space, the resources, the faculty time, and your learner time is really valuable. So you want to make sure that you're really dialing up appropriately the level of learning so that people are challenged. I want to talk first about what are the challenges and some of the kind of theories and education theories behind why advanced learners are so challenging. But then we're going to go into these concrete ways that you can then dial up and down the intensity of simulation so that it's appropriate for those advanced learners. First, let's start with adult learning theory. Always start with adult learning theory. I like to highlight 2 of the 6 basic tenets. Adults want to learn what's relevant, and they have previous relevant experience. Now, your interns or your medical students, you can predict that they don't have a lot of experience, and so a lot of them are going to have the same learning objectives. But again, as you become more advanced, your advanced learners are going to have really complex needs. Maybe some of them have performed a lot of neonatal resuscitations. Maybe some of them have never been involved. Maybe the last time they resuscitated a neonate was 20 years ago. So a lot of variable experience coming to this. Some of these things are going to overlap as far as their needs. You know that the faculty and advanced residents are going to need to do some parallel management and interventions, some task switching, operating while overwhelmed. But again, when it comes to then some of the content that you're going to hit, it can be a bit more, it can be a bit variable. I also want you to keep in mind, you're trying to keep your learner in what's called the zone of proximal development. It's kind of like a Goldilocks zone where they're appropriately challenged. If you overwhelm them, they're going to become anxious and stop learning. But if you underwhelm them, they're going to get really bored. And we're going to use cognitive load theory to talk about how you keep them appropriately challenged and keep them in the zone. So keeping them in the zone, you're going to modulate the content with needs assessments. The context, you're going to need to start using flexible strategies to appropriately cognitively load them. And again, flexible strategies because your learners are going to have different needs. So that needs assessment. Yes, you can do formal needs assessments, but I find that the informal needs assessments are really important for your advanced learners. And when I say informal needs assessment, this is the first 10 minutes of our simulation sitting down and saying, how many neonates have you ever resuscitated? What's the last time you were involved in something like that? Were you the medical student that was like 3 rows back with 40 people in there trying to resuscitate a baby? Or maybe you were at a critical access hospital and you've done this quite a few times. Maybe one of your 4th-year residents has even taught in this area. So you really got to sit down because you don't know what's going to be challenging to them until you ask. So I find that the informal needs assessment is very important. It also lets your learner know that you care about their level of expertise and that you're going to individualize this for them. Now let's get to that cognitive load theory. This is how you keep them in that Goldilocks zone. So I'm not going to go really deep into cognitive load theory, but we all have something called working memory, and it's kind of, I like to think of it as a couple slots that we're using and we're using to problem solve. If people are really using all these slots and they're full, that's when they're appropriately challenged. If they get overloaded, that's when they're overwhelmed. If a couple of these slots are empty, that's when they want to go check their email because they're way too bored and they're thinking about something else. They're thinking about what they're going to make for dinner. So how does this look different between a novice and an advanced learner? A novice, in that moment after they intubate the simulated patient, they have that mic drop moment where they drop the blade, and then they go to walk away, and I say, well, wait, how are you going to confirm tube placement? What are your vent settings? And suddenly you just see their brain explode because they realize they have to do all these things. And you can cognitively load an intern just by asking them these questions, and they start realizing all the things they have to do in that post-intubation period. But with your advanced learner, I expect them to have packaged this so that it really only takes up one working memory slot. And that's just post-intubation care. And you can maybe tweak that or make sure that they're doing it correctly, but it's not going to be cognitively overloading them. So then how do you fill up all the rest of these slots? This is why you have to be flexible. Also know that with cognitive loading, it's not just what you're doing, but it's what they're bringing to the simulation session. And as part of that little informal needs assessment, I also just check in with them and see, how are you doing? You guys all that I teach, you know that I sit down and I chat with you for a few minutes before we start. And I say, how are we doing? When did you work last? What happened? How are you feeling today? Because if somebody is having problems at home, if somebody's just had this horrible shift that they can't stop thinking about, that is all going to cognitively load them during the simulation session. So you really want to check in and make sure that there's not something else that they're working with that day. Now, we don't need to go into details, but sometimes them just saying, I feel very overwhelmed. I know that I might need to dial down the intensity a little bit to keep them in that zone of proximal development for that session. This is the stuff that I think is really valuable. That's all kind of the theory and what I'm thinking about, but then how are you actually using these concepts in the simulation lab? And there's a couple different strategies that I use with my especially my 3rd and 4th year residents. Hopefully someday we'll have more faculty education and we'll have more sim faculty where I work so that we can do this for our faculty, but these are the kind of take-home points that I want you to think about, or at least what I'm doing. So I want us to talk, we're going to go into a little bit more detail on each one, but focusing on presentation or complaint-based cases instead of just cases. We'll talk about what that means. But there's ways that I modulate a lot of the available case materials, so I think it's a bit more appropriate for our advanced learners. You can increase the complexity of individual tasks, increasing the noise and playing with your signal-to-noise ratio, and then also a focus on crisis resource management. So these are the kind of the 4 things that I think are really useful for these advanced learners to dial up that intensity. I use a lot of different sources for my cases, and these are some of the ones that I go to frequently. The emergency medicine sim workbook is really helpful, and it's got some online content paired with it. EM sim cases, there's a lot of different case-based stuff out there. But what I found is that a lot of the times the cases are like pulmonary embolus. And when my advanced learner was approaching a pulmonary embolus case, maybe they did something that, if this hypotensive chest pain patient actually had an aortic dissection, could have been dangerous. But they met all the objectives and the critical actions on my case. So I start backing up on these cases, and I start thinking of how does this patient actually present? So the pulmonary embolus case becomes a hypotensive chest pain case. And what I do is I think about all of the relevant diagnoses I want them to consider and how they should safely consider all of those things. So let me show you an example. I think all my third-year residents, except Arvin, I'm sorry, you haven't done this one yet, so I'm spoiling. I'll have to rewrite something for you. So I used to do an eclampsia case because just in my clinical experience, I noticed that a lot of the residents were not considering eclampsia in our patient population. It's very rare, but we have seizures coming in all the time. Most of the time, alcohol withdrawal, people would consider a CNS infection, but they weren't considering eclampsia. So I took that eclampsia case because I thought, well, if you get it or you don't get it, you still might not have managed that status epilepticus case right. So I backed it up. I removed some of the information from the stem, and instead of eclampsia, it's now status epilepticus. And I wrote, based on the stem, I think there's 7 diagnoses up here that I thought were appropriate to consider. So in this case, instead of just having a woman arrive seizing, I backed it up so it's, there's a boyfriend that called EMS and he heard her fall down the stairs, and she has a history of depression, and she's been stressed lately, and she arrived seizing. And so by just kind of making things a bit vague, I made any of these things fairly reasonable, defined what they would need to do to appropriately consider each diagnosis. This takes a lot less time than you'd think. You can kind of do it on the back of a napkin. And then I'll make one of these grids for this case, and as they're working through the case, I just check off when I think that they've appropriately considered it. Now, if this person is an eclampsia champion and they know everything about eclampsia, I haven't wasted an entire SIM case just talking about eclampsia, and we can talk about whatever else they needed to talk about. I've only had one resident nail all 7, and I gave him a high five, and then was like, oh, I need to make this harder. Let's run through it again. I'll make it a lot harder. But a lot of the residents like this because it's actually how we practice in the emergency department. Number 2, increasing the complexity of tasks. So in your back pocket, have a little hypoxia on the vent. I have a little grid, hypoxia on the vent. If the resident seems like they're really achieving in the case and they intubate the patient, I'll just make them hypoxic afterwards. That cognitive, yeah, I know, you guys know. Every time you think you're got the case, you're like, uh-oh. So have a lot of these things in your back pocket. Maybe the EKG that they're gonna read, they have a baseline abnormal EKG and they need to ask for that and compare it to an old EKG. So there's a lot of little things that you can keep in your back pocket that can make things a little bit more difficult. It also helps them to consider things like complications of the procedures. So we'll kind of move on and talk about signal to noise, just because I only have a few minutes left. So increasing the noise. So the signal to noise ratio is something that I keep track of, and it helps me with this cognitive loading. With your interns, you need all signal. You need to tell them, this is a young woman that arrived seizing. She is pregnant, and you got to tell them all of these things, and then they're like, oh, this is eclampsia, and they will be cognitively loaded just remembering, oh, it's a hypertensive emergency. How do I manage the seizure? Am I going to have to intubate? What was that dose of magnesium? But with my advanced learner, you start increasing a lot of noise. You start dropping information that's relevant and making them have to ask for it. You start increasing irrelevant information. Maybe the EMS guy that drops her off is real chatty, and he wants to give all this extraneous information about how the boyfriend was freaking out. All of these things are increasing the noise. So there's intrinsic and extrinsic. Some of the intrinsic, one of the examples would be that increasing the complexity of tasks. But you can also just make conversations with consultants or family more difficult. You can have people have an attitude and have the resident now need to manage that. You can have multiple events occur at once. You guys know that if things feel easy and you're intubating, suddenly you'll get critical actions called, or people will ask you questions in the middle of the intubation. So you can make it more difficult for them to do any one thing. Also extrinsic. My favorite one is that I just have a big stack of waiting room EKGs, and I start making them sign the waiting room EKGs during the case. Because again, this is going to challenge them. It makes them, transfer calls are great too. It makes them disengage and then re-engage with the case. If I accidentally overshoot the mark, which can happen, and then you just see this freezing, people start taking longer with their decisions, you start seeing them get overwhelmed, that's also potentially something that we can talk about later. I will quickly dial down the noise. I might give them a little bit more signal. I might have a consultant call and suggest the next step. But we can also talk about the amygdala hijack and the fact that when you're overloaded in the clinical area, your brain might shut down. And what do you do at that moment? If this happened tomorrow, how do you back yourself out of that moment? So I like to call this stress inoculation. It's like getting vaccinated against stress. And so you learn how to think in that amygdala hijack moment. So again, it's another learning objective then, if you overshoot the mark and overload them. I always pretend that everything is intentional, so, you know. And then lastly, focus on crisis resource management. I know a lot of people like interprofessional simulations, involving your colleagues, the ancillary staff. Really consider your advanced learners for this. We used to have some trauma, we worked with our trauma group, and we would have some more interprofessional, multidisciplinary simulations, and it was always very challenging when I saw the EM intern trying to participate in this, because their brain explodes. They're worried about looking silly in front of all of their colleagues that they work with. This is really when you need to get your faculty or your advanced learner in that position. Don't lose all of the resources you put together for a big CRM sim by putting the incorrect learner in the hot seat. Make sure that you put that learner maybe as an assistant, or maybe they can be helping with the intubation or helping with a procedure, or there for your senior resident. But if I have no senior residents available, I'll have a faculty do this, because I think it's also valuable for them. So choose the right learner. This is one of those simulations that we did. We've got a second year up on the airway, and we had a PGY4 that was working with a trauma resident. This is a simulated patient. It's not a real patient. So again, if I put an intern in that position, this is going to be very anxiety-provoking. It's going to be very overwhelming, and you don't want to do that to your learners. They're going to get a lot more out of it. Your faculty will get a lot more out of it than the intern, putting them in that position. So that's about 18 minutes. I wanted to see if anybody had any questions or any other experiences, things that you think are helpful. I have my email up there. If anybody has any questions that they want to email to me. And also on Instagram, if you go on, you can see some of the photos of what we're doing. We occasionally post some stuff so you can see what it looks like in the sim lab.
Great talk. I love the idea of adapting the case on the fly as you read your learners. The question I have is, as you're doing a lot of these things, your time of debrief probably increases because you're adding more items to your case.
It can.
And you may be going away from your original learning objectives that you purposely wrote the case with. How do you adapt your debrief to accommodate those things?
Yeah. You have to be flexible, and I think this is why we will only with the advanced learners do one-on-one simulations so that you can really dial it in and modulate it, and then you can also spend time where you think what's going to be relevant to them. So you have your instructor learning objectives. Again, I'm just going to we do a neonatal resuscitation sim, and they need to get through NRP, but I'm going to make sure they hit all those learning objectives. But if they already seem like they know everything and in questioning they're knocking them out, I'm not going to spend a lot of time talking about that. I might just direct them to a relevant article to reinforce what they know. Like, here's the LLSA article recently on managing the unexpected delivery. You seem to hit all this. Great. Let's talk about what actually challenged you. So I will identify what the instructor learning objectives were and what they were able to achieve. I think that's also really positively reinforcing, where they can say, oh my God, all that studying really paid off. And then these were the things I think we should talk about. It also gives them the chance for their learner-driven objectives to just say, like, actually, I want to talk about this. Sometimes they come out of left field with something else they want to talk about, or something that this case triggered in them. So again, learning what's relevant, I find that they engage really well with the simulation session then, and our fourth years are allowed. They have to do one required sim, but then they can ask me for any other simulation sessions that they want, and we have too many requests. Like, I can't even fill them. So I think that they get engaged with that and then want to kind of continue. So I'm okay letting those instructor-driven ones go if they seem like they're achieving them. Sorry, that was very wordy. Any other questions, thoughts? It is at 20 minutes, so if you got to get going, I will not be offended if you get up and walk away. Okay, well, thank you, everybody. I'm so happy about all the people that came here. Yes, thank you. Thank you for your moral support and all of your moral support. And I'll be here to answer any questions if you'd like.